Alyssa?
Here.
Brian? Gallimore? And Ryan? Brian Gilmore? Joshua? Hamilton?
I'm here.
Yeah, I thought so, I was thinking. Angel?
Here.
Tanya?
I'm here.
Spencer?
Here.
Here. Cameron?
Here.
Cameron Jordan?
Here.
Avery?
Here.
Alan?
Here.
Brittany?
I'm here.
Delana?
Here.
Amanda?
Here.
Jessica? Lord? Amber?
Here.
Jose?
Here.
Michaela?
Here.
Autumn? Misty? Kirsten?
Here.
Scotty?
Here.
Chandler?
Here.
Brianna?
Here.
Darkus? Tessa?
Here.
Morgan?
Here.
No PowerPoint? PowerPoint for today.
Did you find it?
This one.
Okay, so y'all know that Redmond is coming today to feed you. And it is going to be Chick-fil-A, but hey, I can eat Chick-fil-A quite a bit, probably every day for lunch. In fact, I did do that once and for weight loss, and I lost, about 30 pounds. It's time for me to do it again. Their, real chicken sandwich on Weight Watchers is only 5 points, so that was easy for me to keep up with. But anyway, so we're going to talk about prioritizing and managing care. So we can read the objectives, understanding the prioritization for the RN to work more effectively. suggestions for prioritization of care and recognize how they can improve patient outcomes. Understand the importance of plan of action for effective time management and client care, if there is such a thing nowadays. Understand the role of the RN in helping the interdisciplinary group address priority patient needs. So, so we know, and this kind of goes back when you were I used to teach the ER module, and you're triaging patients. It's pretty much the same way, and things that we've already taught you also from the very beginning: airway, breathing, circulation, are the first level of Maslow's hierarchy of needs, which is meaning what? Physiological needs. And then the second level client problems, such things as mental status change, acute pain, acute urinary elimination, untreated medical problems requiring immediate attention, diabetic needing insulin, abnormal pathology lab results. You know, that isn't always the issue though. If you have a patient, I mean, yes, airway, breathing, and circulation is as far as it comes to maybe CPR or immediate impending arrest or death. But if a patient has a mental status change, what is that could possibly be? Circulation, because it could be a stroke, right? I borrowed these PowerPoints and then kind of made them my own from Dr. Mullinak's, but I would not put mental status change as a second level client problem. Not in any way. Because to me, that could be definitely a stroke. That's would be the first thing I would think of, and then what's usually the other thing? Electrolyte imbalance of some type. And what happens with an electrolyte imbalance, that it can lead to dysrhythmias, so issues. Acute pain, yes, second level. Acute urinary elimination, patient's got to get up to go to the bathroom, absolutely second level. Patient requiring insulin, unless they're, I mean, I hate to say it, but hyperglycemia, unless they're in diabetic ketoacidosis, still, it would definitely be second level. And, but I would not agree with the mental status change. And also, abnormal pathology lab results. What if you get back a patient that has a potassium of 6? That's gonna be up there with my first level, isn't it? Because the potassium level of 6, that is an emergency that has to be addressed. That's just as bad as the patient having the acute MI. So, or a potassium level lower than that, because that's gonna lead to lethal dysrhythmias. So, it just depends on, what the level would be. So third level client problems, the ones that don't fit into the first two, patients complaining about something. And I noticed that students tend to, if you have, which patient would you see first, and there's a patient that's vomiting, they will go to that patient's room first. So if I'm in there vomiting, you would run in there to see me first, rather than someone who is having an altered mental status. You'll always assume that when somebody's vomiting, unless they say, that patient has a hint towards dysphagia, yes, that would be the patient I would say first. But would y'all want to run in the room if I'm vomiting? if I'm in the hospital for, maybe I had a heart catheterization, and for some reason I'm throwing up, I can take care of myself, right? And then most patients, don't we have their head in the bed up 30 degrees? So unless there's a hint to that patient having dysphagia, or that, for whatever reason, just the patient that's nauseated and vomiting is not the priority unless there's a hint to dysphagia in that stem of that question. Patients that are, like I said, upset, angry, pain, unless it's chest pain. And of course, patients that need education, that can wait. If you're practicing right now, you see that it's having to wait. So prioritization, the act of deciding what should be done first, who are you going to see first, and what activities should follow sequentially, establishing an order list. And you should be able to do that. It's just like, and I think I did this with you guys when I taught you perfusion with CP. If somebody is in cardiopulmonary arrest and you've assessed them, if you start CPR immediately, you have killed that patient. Because you've got to call for help first. If you don't call for help, you may as well not even start CPR, because how long are you going to be able to do it? But the whole reason of calling for help is to get help. And also, most people who go into cardiopulmonary arrest, they're going to be in VTAC or VFib. And if you do not get that defibrillator in a timely manner, then, they're up to pressure by paddle. But so in prioritizing, you've got to think of things like that and remember that I want to call for help first, and then I will start CPR. And of course, we know, again, the ABCs, but it's not just ABCs. It's where airway, breathing, circulation, disability in that head injuries, like a patient that has fallen on your unit. You want to make sure the very first thing is they don't have a head injury. They don't have a brain. Yes, they may have fractures too, and you want to check that out. But the very first thing, you want to check them neurologically. And then also, and again, teaching in the emergency concept, I taught that airway, breathing, circulation, disability, with head injuries, stroke. Of course, that goes back to circulation too. Another disability, suicide, attempted suicide, should be in there. When you're looking at the D's, think of attempted suicide, because any patient that is suicidal is going to be your priority. And then there's exposure, whether they're hypothermic or hyperthermic. And then, of course, the last thing is just simple safety, a safety issue. It may be something so benign as that the patient is getting up to go to the bathroom and they do not have their non-slip footwear on. I'm going to go see them first. Why? Because then that just leads to a snowball effect. If they fall and they have a head injury, or broken fractures is bad enough. So, and this is not just to prepare you for NCLEX. This is to prepare you for life, in the nursing profession. So it's not just ABCs. You've got the ABC, D's, E's, and then safety issues. Because when you pass NCLEX, you've just passed the minimal level of safety to practice nursing. So I did go ahead and I added the disability, but airway, may not always be just and you already know this from standardized testing, that someone is choking, or it may be something more to the effect of, you know, like, if you have a patient on the ventilator and you don't secure their hands, then they're gonna lose their airway because they're gonna pull it out. So just the fact that you need to, you know, I don't know if the wording would be restraint, immobilize their hands, whatever. And then breathing, again, it may not just be that their O2 sat is, it may not even have an O2 sat, period. But breathing can be, say, a COPD patient. They're all about anything that goes on with them, we have to worry because they're breathing. If they're admitted with exacerbation of COPD, that's our priority of anything that we see change in their condition that could cause, let's say, infection in those lungs. If we don't clear that up, then it's going to alter the airway and the breathing even more. Circulation, it's not just that, you know, they're in intact defib or cardiopulmonary arrest. It may be circulation to the extremities. It may be circulation as far as I've mentioned on here, dysrhythmias. Of course, it might be blood pressure. It may be the most common dysrhythmia out there. Do y'all know what the most common dysrhythmia in nursing is? Atrial fibrillation. We had a patient who had stent placement. He did not have an MI, but when they go in to place a stent in a patient, it's going to raise their troponin level because you're going in there and the physician is irritating, doing a little bit of damage to that coronary artery, and for every action, there's a reaction. So it's gonna raise the troponin, and it's gonna cause some irritability. So we had this patient who had come in, he needed another stent. He had just been in several days before for a stent. Don't know how that came about, but respiratory came in to give him a breathing treatment, so he must have had COPD also. I came in to give him a breathing treatment and he went into atrial fibrillation because he already had that irritability. And then you come in and any breathing treatment is going to have what? A bronchodilator. What do bronchodilators do? They cause tachycardia, yes. So he had the breathing treatment and then he went from sinus rhythm to AFib with RVR, rapid ventricular rate, rapid ventricular response. So then the patient was complaining about how long it took the nurse to come down because he was having chest pain too. Who knows how long? That nurse could have been there in 5 minutes and the patient felt like it was 50 minutes, you know. So, but anyway, and then like I said, disability could be stroke, it could be head injury, neck injury. Again, I like to always put in there that suicidal patient. And then exposure. You know, we live in a state that has all 4 seasons, so we could have, now if you were in an area like Alaska, you probably never have to worry about hyperthermia, but you would always be worried about hypothermia. But here we could have either one, hyper or hypo. My most famous, I guess, nursing situation, and none of you will know this because you're so young, this person, but there was a movie and a book written about a lady that poisoned her husband, killed him, and then her name was Marie Healy. I mean, the story, it made a great movie. This woman was so, they arrested her for her husband's death, and they didn't realize that she killed her husband until her daughter was admitted with at UAB, and she had these strange symptoms, and one of the physicians looked at her fingernails and thought of arsenic poisoning. Tested her and realized she was suffering from arsenic poisoning, and then they had her husband's body examined, Maria Hilly's husband's body examined, and realized he died of arsenic poisoning, and then they tested the son, and he had heavy levels of arsenic in his body too, her son. So, anyway, this lady, some big multimillionaire banker, because she was so charismatic, he put up money for her bail, and she got out. So even when she went to prison for the death of her husband and attempted murder of her daughter, they gave her a weekend pass from juvenile subway. Imagine that. So she was on a weekend pass, and her then husband, she married another one, anyway, she told him they were on the way to wherever she was supposed to be dropped off, maybe back at juvenile subway. And she said, let me out of the car, I'm not going back. So he let her out of the car, and it was like in March that the temperatures were still dipping down at night into the 30s. So this woman the next day, she went out on her back porch for whatever reason, and there's this person laying on the back porch that's barely alive. And so she calls 911, and they bring her in, and it was Maria Hilly. And so we worked on her in the ER for a couple of hours because, and you probably learned this, with hypothermia, you cannot say a person is dead until they are warm and dead. You've warmed them as their body temperature as high as you can get it. Because the better outcome for anyone that has asystole is asystole due to hypothermia. Those patients do well from asystole. Any other cause of asystole is not very good. But we worked on her, it seemed like almost 2 hours before they could finally pronounce her dead. And of course, like I said, none of you were probably even born back at that time, but it was just but that's where I learned about someone with hypothermia. They cannot be pronounced dead until they're warm and dead. That you tried everything. So again, Maslow's hierarchy of needs, basic needs. So, of course, breathing is pretty much a basic need. Circulation, the ABCs. Food, water, sleep. Of course, again, we know that the ABC, D's, E's, and S's are going to come first. Is this a repeat already from 115?
Mm-hmm.
Also Kaplan, I'm sure not Kaplan, but Hearst.
First.
And of course, Kaplan's going to go into it also. And then safety, security, protection. If you have a person that comes in the emergency department that's been traumatized, especially sexual assault, then we know that safety is their priority, feeling that safety and security needs. So that might be a priority that you're faced with on a question. And that goes back to critical thinking and love and belonging. Maintaining someone's support system, and then self-esteem, of course, self-actualization, that would be probably the lowest. So again, I've already mentioned my list of airway, breathing, circulation, disability, exposure, safety, but I decided, and I will go back later, recently to put that, in that disability, the suicide, predicted suicide. Pain, You know, pain, if it's just that they're complaining, no, chest pain, that's a whole different thing. But pain, if they're complaining of pain and there's other things going on, they're complaining of abdominal pain, they just had surgery, their blood pressure, because you've got to add some other things in there for it to be a priority. Their blood pressure, the systolic is below 90, or you can see that it's trending downwards. That makes you think they're bleeding inside, right? They're bleeding somewhere from that surgery, the abdominal. But if, you know, they're in extreme pain, a 10 because they've had knee surgery or whatever, unless they're complaining of it in the calf of their leg, because they're probably
Thinking of blood clot.
DVT. Also, when I speak about chest pain, myocardial infarction, sometimes they want to draw you to that as making you think that's the priority, and it's not tricking you, it's trying to get you to critical think. If a patient with a myocardial infarction, they know the students will go, oh, they've had an MI, that's the priority. You gotta read the rest of that. Because a patient that's had a myocardial infarction, they're usually in and out of hospital within 2 to 3 days. If not, they're in cardiogenic shock. Because with myocardial infarction, again, it's no more than 2 days, 3 days at the max. Maybe if they have a stent also, or they've had some complications from dysrhythmias, but just a myocardial infarction, you've got to really, don't just see that word or that term, that diagnosis, and think, oh my God, this is the emergency. And that goes back to always reading all 4 of the choices, or if it's select all apply, we know there's more than 4 distractors. But I have seen questions on standardized tests where someone had a myocardial infarction 4 days ago. Well, heck, they should have been at home, or if that, they're going to be in the ICU in cardiogenic shock if they had an MI 4 days ago. There shouldn't be a reason they're still on and searching it. And as you can see up here, Kaplan teaching and probably Hurst, that an acute situation is going to trump chronic, and then of course we've got to differentiate between what is urgent, non-urgent. But I always like to put my eggs in one basket, and that is this patient stable or unstable. And when I teach dysrhythmias, that's the thing that I also say, because you can have a patient with a heart rate of 30 and then be stable. How do you know they're stable? First thing you've got to do is you've got to assess them. You can have a patient with a heart rate, believe it or not, 140s, 150s, and they may be just a little bit anxious or a little bit lightheaded, but they're stable enough that, they can go ahead and give them an IV medication to decrease, to control that heart rate. If they're unstable, and of course, I didn't teach this, but I always say, if you've got someone with SVT and their blood pressure is in the dirt, you've got a cardio dirt. Because if their blood pressure is low, you can't give them any kind of medication to slow heart rate, because that medication is also going to lower the blood pressure. So with any dysrhythmia, I always say, are they stable or are they unstable? So I put all my eggs in the basket, and I'm looking at these distractors and saying, is this patient stable or unstable? Because the unstable patient, of course, is the one we're going to see first. So, actual problem versus potential problem, that's going to trump most of the time, except we did have a situation. We had a patient who had statin-induced cirrhosis of the liver. He had been on statin medicines. They went unchecked because physicians are doing this more and more, until he had full-blown cirrhosis. But anyway, we know that with a fluid volume overload, the body pushes fluid into any cavity it can, especially if you've got some renal issues. So, This guy had pleural effusions, but the most important thing is he had a pericardial effusion. So I was teaching the student, this is a potential nursing diagnosis, him having pericardial effusion, that is more pressing than anything else unless he is actually in cardiac arrest, because there's a fine line between that pericardial effusion turning into cardiac tamponade, and then they're in obstructive shock. The worst kind of obstructive shock, if it's not recognized early and they tap that cavity to pull out that excess fluid, that patient's gonna die. But NCLEX, they're not gonna give you anything, and I'm not either, anything that complicated, but that's what you're going to run into in, real life. And even the physician had written, but nowhere in that handout report was it mentioned. When I was reading through the chart, reading through the electronic health record, I noticed that the doctor said, pericardial infusion, need to watch carefully for tamponade. Now, in the old days before COVID, they would have put that patient in the ICU for closer observation. But now, with 9 to 10 people waiting on the ventilator in the ER, they can't take up an ICU bed for that. So. And of course, anybody that has unrelieved interventions, unrelieved symptoms, a sudden occurrence, or an obvious change. Knowing the needs and priorities of each client. So this is another thing, and this kind of goes back to delegation, in that what staff what are your available resources and staff? So, if you did have an example of a patient trying to get out of the bed and they do not have their non-slip footwear on, who can you delegate that to?
Okay.
Exactly. So there may be something in the stem of that question. If it has, what resources are available, it's wanting you to critical think, okay, that is an emergency because they can slip and fall, but I can get the UAP to go see that one. But the UAP can't go assess an unstable patient or do an intervention on an unstable patient. I guess they could, if somebody's in a cardiopulmonary arrest, don't the techs also have to have CPR? So they could call for help, begin CPR. That's about the only thing that I know of that the UAP would be, in an unstable patient, could begin treatment with, because all nursing staff are trained, or they should be. Can't imagine that not occurring. So again, we have to consider more than just the patient's condition, but also the staff that we have available. So with a lot of this, I feel like I'm preaching to the choir, since most of you are already nurses. How many of you are working in the nursing field? You've already been up close and personal with a lot of these things. When I was in LPN school, I was working as a waitress in a restaurant. I did not change my job. I wanted to. I envied the people that were already techs, but to me, I was in a career that I was familiar with. I was making good money, and I was not going to put that on me as an extra stressor. I just couldn't do that. So you know, again, I envied the people that were already working as assistants in the hospital, being exposed, to patient care, but I just was not going to put that on myself to learn something new. But it all goes back to what you learn, even at the beginning in nursing, with the skills that you're validated on, you know, what was one of those validations that you always had everything you needed, right? You collected your, supplies and went into the room, and we know that teamwork always helps as far as like being a helper down here at the bottom. And I don't know how well you can do that these days because you're barely making your own, caring for your own clients, but I guess there may be situations where you absolutely have to, especially if you have a patient that is, unstable and you know that nurse is drowning, but you do it more for the patient, you should, than the nurse to help out. But right now with the staffing as short as it is, it may be every man for himself, I don't know. And then also encourage family participation in care. I can remember in the ICU we had this, adult, he was in his 20s, but I thought of him as a child because he had muscular dystrophy and he was of small stature and he loved to watch cartoons. He never progressed past that stage because of his illness, and so I still wanted to call him a child or a grown-up. But anyway, he wanted to go home, but his disease was progressing to where he had to have a permanent trach. But he had thick secretions. The family wanted to take him home, but even at the hospital, we were having to, because he was having to stay in the ICU, I think the best situation would to have let the family stay in there to see if they would respond when he started plugging off his trach, if they knew how. But I remember one of the nurses saying, he can't go home because he'll plug off his trach and they won't know how to take care of him. And I'm thinking, why aren't y'all doing that now? Bringing the family in to show them this and seeing if they will respond. I was talking to him because there was a cartoon on one of the old Looney Tune cartoons, and I love the Looney Tune cartoons. And I had just left his room and went to another room, and then I heard somebody calling his name and telling him to breathe. And so what had happened is he plugged off. And when I walked back over, of course, other nurses came to help. He was blue, his heart rate was in the 40s, and I immediately responded by going to get that crash cart because, you know, I worked in ICU for 11 years. But he didn't need anything off that crash cart. He just needed oxygenation. He needed that mucus plug removed. So what they did is they took him, and he might have still been on the ventilator, I don't remember. But anyway, they ambooed him and got that mucus plug out, and he was better. But I'm glad that I brought the crash cart because his heart rate was not responding as well either. So they thought he was gonna need some atropine. But anyway, family's participation could not only help assist you, but also there should be family participation of it. And critical thinking on those nurses' part, especially the one that said he can't go home because the family, he'll plug off and they won't know what to do. Well, even though it was the ICU, they should have made an exception for that family to come back to see if they could respond. And then we, in the ICU, they always have the interdisciplinary rounds where the interdisciplinary team talks about patients and what, from their professional point, what that patient will need. And then they collaborate. And Again, that can be physical therapy, respiratory, pharmacy, of course, the physician, dietitians, occupational therapy. Let's see if this one still works. It's not. So do I have to do this or no? So. I don't know. Has anybody tried to go to this?
It works.
So I don't know.
I had to hit control and click to get it to pull up.
So.
No.
I just did it wrong.
Can I go into like the actual slideshow instead of doing it in the, my presentation mode?
So just copy and paste, is that what you're saying?
Probably, you want that way.
Okay, so this presentation kind of tacks on to the priority of the very first testing strategy presentation that I've done. So has anybody not seen my original testing strategy presentation? So a couple of you. So I'll take my time when I go through just the intro of what this is, and then whoever hasn't gotten, so when you are done, just remind me and I'll email you the original presentation so you have it. And I think the 440, are you 445 as well? I think some of the 445 instructors have posted it under resources, actually in the resource tab. So basically this is just a PowerPoint to figure out who I see first, who's the priority patient, who should be put with the most experienced nurse. So just get along. So I kind of created this little spectrum. So the piece of paper that I've
Yeah, I feel like this is probably going on the same thing that you're on from
chronic to acute. So let's say you're looking at a question and you want to know who is the priority patient. Think to yourself, is it a chronic situation or is it an acute situation? The second thing is it
I'm gonna
a
let you
non-emergent
watch
situation?
this at home. And then the NLEX strategies too. Now, used to, before we had the Hearst, review at the beginning of the class, this would have been more of a priority for you to watch these. But, now, I'm not as concerned. briefly go through these just to look at the points that I want to stress for the next test. Is that okay with you guys?
Perfect.
So, again, as you progress through your education, it can continue, but again, I have said that the best bang for my buck is this 2-year degree here. So, but if you go back for your BSN, there's very little hands-on patient care to do. It's mostly, you may have to do some community help. I don't know, I did. But, you're gonna learn about nursing theories, and of course, Florence Nightingale was the first nursing theory. And I think of her more right now because of the war in, or what is going on in, Russia and Ukraine. Because Crimea is not far away, and Russia is using Crimea, as a strategic point, and that's where Florence Nightingale wrote and learned of her, about her theory, or conceptualized her theory, and it's all about we talked about manipulating the environment. Now, who wouldn't have thought that keeping cleanliness, we know cleanliness is next to godliness, but she had to come in to realize that these poor soldiers were, not getting personal care that they needed, the bandages changed, even psychologically, open up the windows, for sunlight for them to be able to see. In the old ICU that I first worked there, the window was to the side of the bed, and the patient could never see out the window. So if we had a long-termer, then I would take the bed and turn it around so that they could see out that small window, just to get a view of the outside of. Because to me, I cannot stand to be in a dark place. I like that. And that's why I get seasonal depression too during this time of the year. But of course, if I lived in the Pacific Northwest, I'd really be in trouble, or someplace like Ireland where it's cold and they don't see the sun that often. I just couldn't live in a place like that. But anyway, I would turn my patient's bed around, even if they were on the ventilator, if they'd been in there for a while, and they were, well, I can remember those that were not cognitively aware, and I still did, if they had been in there for a while. But anyway, so back to Florence Nightingale. She manipulated the environment to improve the survival rates. And then we know the differentiation of practice for the advanced, practice nurse is, what is that? Someone who is certified beyond the level, and also with that they have to have an educational level also. So with that, they would have to have at least a master's degree in nursing, and that would be the nurse practitioner, the clinical nurse specialist, the physician's assistant. Of course, I don't think they consider themselves as part of nursing, advanced practice nursing. And the registered nurse, and we'll add more to that when I go over here, the LPN, and you'll see sometimes licensed practical nurse, we use that term, and then other places use LVN, the licensed vocational nurse. And then the UAP. Back to leadership management, we know that management is the coordination of resources, mainly time, people, supplies, and managers should be good leaders also, but that's not always the case. Leaders inspire people to achieve common goals. And we would hope that our nurse manager could do that also. And yes, the manager, they're busy coordinating, again, people, time, and supplies. They plan staffing, they have to plan the staffing mix. And of course, that's according to the acuity level of the patients on the unit, but I don't see that so much anymore because it's like anybody that's in the hospital now, they are high acuity. There may be some that do not fit so much in that. Because we know what's the highest acuity level of a patient, it seems, is that patient who requires total care. They have, just on the med surg floor, if they just have a feeding tube, that right there is high acuity, because you're having to not only do vital signs. We know they have an extra vital sign, and what is that? Residual and placement of that feeding tube when you do vital signs, and then the medication pass. And then if somebody is receiving full liquid diet, what is also going to come about sooner or later? Diarrhea, yep. And then not only that, if that patient's that high acuity that they're requiring a feeding tube for nutrition, what is their skin going to be like? Their skin, they're probably going to have a lot of breakdowns. So anyway, so that kind of acuity, high acuity patient would be a lot more advanced than someone that's in with chest pain or maybe a myocardial infarction, and you're having to, you're taking care of them. That's a myocardial infarction, but still, their acuity is not near as high as that patient. That patient may be more stable, the one with the feeding tube, but the care is a lot more intense, more care required for that patient. And again, the nurse manager has to determine the acuity level of the patient's on the unit per se, in the perfect world would be in place to determine the staffing mix. And we know the managers, we talked about, they are responsible for the safe environment of the clients and the staff. Acuity level, I just talked about that, and the yearly budget, hiring and firing, they make decisions on that, and then the annual evaluations. And I said we were not going to go here in these advanced management theories. Someone who possesses integrity is, and you see that it is number one up here. If you're trustworthy and honest, I'd rather have that over any of these other things listed here. Because if you're trustworthy and honest, then probably the other things are going to come in with that trait, but it doesn't matter. If someone is not trustworthy or honest, they should not be in nursing. I was talking with a student earlier before class started, and they were talking about having had 3 tube feeders in their patient load, and how much time tube feeders take. And I just said that, well, a med pass, you know, y'all, those of you that are already in the real world, you know, while in clinicals we teach you that you've got to crush each med separately, put it down and flush it. What if you did that with 3 tube feeders? That would take hours. So this nurse was saying that one of the tube feeders, someone, for whatever reason, had pushed the connection from the feeding pump into the tube, so jammed it so far in, they could not get it out themselves without help, because they were afraid they were going to dislodge the peg tube. So they went to get assistance, and so, you know, then they got to take that person away from what they got to do. And they finally, 3 or 4 days later, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got it out. And they finally, 3 or 4 days later, they got succeeded in getting that part. There are nurses, and I hate to say that, they would have scanned the medicines, dumped them, and would have gone on the other way. Or maybe scan the medicines and said, okay, I'll come back to this one. And then they didn't get around to coming back. So again, if you're trustworthy and if you're honest, and my conscience would not allow me to do that, even if I couldn't get it, the tube apart right then, you know, I'd have something to remind me that I had to go back to that patient's room to get those medicines. But anyway, again, trustworthy and honesty, integrity. You want nurses with integrity. You want staff. That is the number one leadership quality. And, you know, these other things, they're nice, you know, to have, but you can't look at someone and say, oh, do you have a balanced work life? We hope that everybody does, because they're gonna be in better shape mentally and physically, but, in a perfect world, and maybe in the perfect world of NCLEX, and, positive attitude, self-awareness. I keep thinking that, Redmond's going to be calling me. Problem solving skills, I mean, that's pretty much what critical thinking is. So everyone should have those. And so I did focus on the behavioral theories, and about the person that has the autocratic leadership management behavioral theories. Those people are the ones that you do not want to work around unless that, you know, it's my way or the highway, unless it is a major disaster and one person has to jump in and decide, okay, you go do this. It's not, do you want to go triage patients that are coming in out in the parking lot, or, you know, whatever. But the autocratic behavioral theory, again, you wouldn't want to work under someone or near someone or a coworker that has, you know, my way or the highway attitude. I do find that sometimes when there was a particular area particularly that I left in the hospital because I felt that's the way the nurses were, and I kind of run into that a little bit on the unit, that they are ignoring the students. And so I finally went to the charge nurse and just said, if that nurse is taking, if she's assigned that area, we're not taking her patients. So, she might have been a split between autocratic and laissez-faire. I don't know her description, but anyway. You want democratic, is where the leader manager does want input from other people, from other workers, but they still, you know, of course, some things, as far as staffing mix, that's their responsibility if it's the manager. Laissez-faire, nobody wants to work under somebody that's autocratic or laissez-faire consistent. Laissez-faire, there's not a place for that person anywhere, because they're just, procrastination is their number one, and it's whatever, you know, I'm just here for the beer. That's what one instructor was once talking about. Of course, she's gone now. Yeah, sometimes these students, they're just here for the beer. And then we talked about bureaucratic. It's going to be more the people that you don't see, especially in the corporate office, who are managing that hospital in addition to several other. And then sometimes even the CEO is a bureaucrat that you don't get any, input into. And, the autocratic leader will be the one, and we talked about different kind of power, and their power is the coercion. And then the Democratic leader, let's share, let's have a show of hands, let's, everyone have input. And again, the laissez-faire leader. And again, I talked about the types of power and leadership, legitimate, coercive, reward. But, if you work with a manager that's utilizing coercive power, you don't want to stay there very long. Conflict, the types of conflict, you know, intrapersonal, interpersonal, organizational. You need to be able to differentiate those three. And then resolving conflict. What did I tell you the first step in resolving conflict?
Listen to both sides.
Because if you can't identify the problem, that's just like in a patient. If they can never identify the problem, then the patient's not going to be stabilized or treated. They're gonna die if they can't identify the problem. What's causing the situation? Instability in nursing, instability, as I said, is everywhere, especially in high stress workplaces. And what's higher stress than medicine and nursing? And I talked about ways of dealing with instability and the statement of the ANA, their position on instability and bullying, American Nurses Association. Sexual harassment in nursing, talk about those. So again, we're just reviewing what I have already talked about. Having gone and successfully completed 115, you should know, the 5 rights of delegation, because, can an LPN delegate to, the RN? No. Can the LPN delegate to the UAP?
Yes.
Can the UAP delegate to anybody? And then the RN is the hierarchy, we know, that delegates to the LPN and the UAP. And again, you need to know those 5 rights, the right circumstances, the right person, the right direction of communication, right supervision, and evaluation. The Nurse Practice Act, I talked about the Nurse Practice Act. It is the Bible of what you do, standards of care, policies and procedures. So yes, the hospital's policies and procedures should reflect what the Nurse Practice Act says. And, for instance, I did not really know for sure if UAPs could do finger stick blood sugars. I knew the hospital, allows them to do that. So when I was looking up the Nurse Practice Act for Alabama, it did say, it did note that UAPs can collect finger stick blood sugars. Now, if you had a scenario that the patient was having signs and symptoms of hypoglycemia or hyper, that's, for that matter, would you want the UAP to go get the
No.
finger stick? No. But again, Nurse Practice Act is the highest authority of you determining what your responsibility is as an RN, and then also for the people that you're delegating to the UAP the LPN and the UAP. And what is the task of the UAP? What task can they complete? Simple, routine tasks, right? And we know that, and I did copy this and paste this out of the Alabama Board of Nursing. So the thing here is, assignment. So the assignment is transferring responsibility and accountability for nursing activities from one licensed nurse to another. When do you think that occurs most often?
Shift change.
Shift change. Absolutely. And then assignment unlicensed individual, and we, as licensed nurses, whether you're an LPN or RN, we do have to be accountable for the UAP because they do not have a license. They don't have a license to lose either. They can lose their job, but they wouldn't lose their license because they don't have one. And that's another thing that's an issue today with high acuity patients, short staffing, is that, and someone said, and it's a smart thing to do, that they brag on their techs and tell them what a good job that they've done. And then maybe if they didn't do such a good job, maybe there's some way that you could help them, or if they're just worthless, you might just have to report them. But if you do have someone, a tech, that is doing a good job, you need to remember to do things, but especially to verbalize appreciation for those people, because they are the backbone of the workforce. And whenever we delegate a task, we want to make sure that that patient has that individual is competent in the skill or the task that we're delegating, knowledge, skill, and experience. And of course, the health of the patient. We know that if it's patient's unstable, the RN is the staff that needs to care for that patient. But we always want to know the knowledge, skill, and experience. And I know I talked about, someone that is being reallocated or pulled from another unit because you're short-staffed and they're from psych or OB. They're still nurses and they should know, nursing care, but they've lost a lot because of the specialty that they're in. Just like, I learned about OB, but again, I wouldn't want to be placed on OB or psych for that matter either. I would want the most stable patients. And talk about LPN and delegating, because we know that in the perfect world of NCLEX, the LPN, they cannot initiate any part of the nursing process. They can utilize interventions, but they cannot do a full assessment. They cannot diagnose. they cannot, plan, they can implement nursing interventions that the RN has placed on that plan of care. And they cannot do the evaluation, so they cannot use any part of the nursing process. And what is the nursing process? A delicious pie, assessment, diagnosing, planning, implementation, evaluation. That's in the perfect world of NCLEX. But, I had a student that I was validating in 113 yesterday, and she's already starting to work as a different level type tech that they're using now. Like maybe she could start IVs and some other things, but anyway, she was saying, now at the hospital, we just use the garbage can instead of, you know, how you were taught to roll down that bag when you're starting the Foley catheter to put the dirty things that you use in there. She said, we just use the garbage can work. I said, listen, that's the thing that you need to start learning. You cannot think about what you do at the hospital. You've got to think in the perfect world of NCLEX, what would I be able to do? Just erase from your mind what you're doing at the hospital right now. But again, in delegation, we always want to know the knowledge, skills, and experience of that person with that task. What did I say about anything sterile? That the UAP cannot obtain sterile specimens? And also remember that LPNs can give IV antibiotics as long as they're through the piggyback. But as far as in NCLEX, because they are not, the hospital will train them on IV medications that they can give, but they cannot, as far as world NCLEX, they're not going to be given anything IV. If that patient requires IV push medications, who are you gonna delegate that?
The RN.
Yeah. But we know, and that's why you can't look at what's actually done, that you're seeing in that, those LPNs have been trained that they can give like Lasix and protonics. They can't give antidysphotic medications or anything that could affect the blood pressure IV. But I don't even think NCLEX would go there. They're more the effects of that medication that's being given, the side effects or why it's being given, what you need to do, the implications. And we're going to talk more about the Board of Nursing in Unit 3. Here again, the RN cannot delegate. The LPN can carry out the interventions that the RN has established as the plan of care. So as far as the perfect world of NCLEX, the LPN is not going to be able to initiate any part of the nursing process. And as far as assessment, we know the LPN can do what? Focused assessments. They cannot do any type of education, so before you choose a distractor that you know would require the education process, even if it's minute, you think, oh, it's so simple, but it's still an education. For instance, if you were, would you, in the perfect world of NCLEX, would you delegate to the LPN to teach the patient to instill eardrops in their ear? Because even something that simple, because they cannot teach. And I talked about competencies, and that goes back to the skill level before you delegate, knowledge and skill level. And then also, like the Joint Commission yearly has competencies that RNs also, or every licensed nurse, but particularly the RNs, like blood administration. The LPN would also be included as far as the glucometer, being able to do the controls on that. The other day, we were getting blood sugars and the student didn't know what was going on. Of course, they were a 113 student, but the glucometer had not been, what is it called? The controls had not been done. And I could have gone to, and just put that one down and gone and got the other one for the unit. But you know what I thought? I'm a nursing instructor. I've got time to do this for the nurses, but not only that, even though the student doesn't have to know this, I'm going to do it, and they will get to learn how to do the, what is it called, the calibration, that's the word I'm looking for the control levels, yes. But all I can think of is how busy those nurses were that, yes, I could have just said, oh, we're not gonna use this one, we'll go use the one that's already calibrated. But I knew that I could help the nursing staff, and at the same time, my students could learn something and be excited about it. And that student was, oh, I didn't know this. We also have, and we talked about advocating, that we have to step up and as an RN delegating, if the person that you delegated care to is not practicing safely, then we need to speak to them in a non-judgmental manner. We don't want to confront anyone. That's not a good situation to lose your job or over that. Confrontation is what? Instability. And it may be, so the first thing you want to know is, you know, what the issue is. Again, identifying the problem. Because I can remember in the intensive care when I first started out up there, I felt like I was just, because everybody else was an RN except for me. And I felt like I was having to beg for them to do the things like, you know, morphine for me, IV, and really, it was a nursing shortage, or they would have needed an LPN in the ICU. But, so I'd never had any nursing experience, so I'd been a waitress. So I come to the ICU. So one night, oh gosh, I'll never forget, my mother was a cardiac patient, and when she took her nitroglycerin at home, you know, if she started having chest pain, she would take her nitroglycerin and wait 5 minutes, and then, you know, take another one. Back then, they didn't have automatic blood pressure cuffs that you could buy at CVS or anywhere else. But anyway, so this nurse was really busy, and her patient was having chest pain. So I was always stepping up to help those nurses any way I could, because I knew what they had to sacrifice for me. And in fact, it got to the point to where they said, we're just gonna teach you how to do these things. So, I wouldn't do that now, not in this day of the high acuity patient, but they taught me, you know, how to give IV medications, how to help the physicians at the bedside to scrub, to put in invasive lines, central lines, swan gain catheters. We even put in we drew our blood gases if the respiratory therapist wasn't there. We even put in arterial lines. So I've been in the ICU for 5 years, but if my patient needed an arterial line, I would go and say, you know, and they'd say, we're gonna teach you how to do this. And then after that, I would say, okay, I'm gonna do it, but you're gonna sign that you did it before I go do it. But anyway, so this nurse, she was busy, and her patient started having chest pain. So I went in and I gave him a nitroglycerin, and I wrote the time that I gave it, and then 5 minutes later, I had to give him another nitroglycerin, and then the chest pain was better, but it was not relieved. So 5 minutes later, he still had the chest pain, it was better, but it was still there. So I gave him a third nitroglycerin, wrote down the time. So I went to her and I gave her the notes on my paper napkin, because that's what we used to, we didn't have EHRs and WOWs. So anyway, she just chewed me out. She said, what was the blood pressure after each one of these? And I said, I don't know. She said, did you not know that you gotta check the blood pressure before you give a nitroglycerin? No, nobody ever taught me that in school. And you know, we never checked the blood pressure for my mother when she was taking nitroglycerin. Of course, she was stable and at home, and this was an unstable patient, but she really didn't thank me. Instead, I got chewed out for not checking those blood. But you know what? I never gave another nitroglycerin without checking that blood pressure before and after. So anyway, always be as nice and cordial as you can, but if someone is ineffective and unsafe, and they continue, then you're gonna have to do something. And you're gonna have to report them, and who you're gonna report them to? The nurse manager. And always remember too, that supervisor position, is always there so that they can troubleshoot all over the hospital. So if you need an extra staff person for an immediate task, you know, you can always call that supervisor in the perfect world of NCLEX. They're just sitting around with nothing to do. And it used to be that way, but not anymore. So again, LPNs, reinforced teaching, focused assessments, and they're going to have stable clients. The UAP, simple repetitive task, and if it's a task that they've never done before, and it may be something that you can just go in there and teach them and help them with, so you've taught them, you know they're competent in that then, and so the next time that patient needs to get up, you know that they can do it if you feel. So instead of you having to go in every time to help that patient. I think I've covered. What is evidence-based practice, John?
It's been proven that it works. It's been effective.
And with evidence-based practice, every nursing intervention, and even physicians, every intervention that is performed on patients, it's been through research. It's been researched, and one research study really doesn't tell you a lot. The only way that an intervention remains in use is that you replicate that research study and you come out with the same outcome, that it is supported. Nothing's ever proven in research. It's supported with data that it is safe, it's more beneficial than harmful to the patient. So anytime that there's a policy or procedure, it should have been, based on evidence-based practice. And I don't know if I told you, but, I was looking for a project for my, DNP, and I was asking a nurse educator, and she suggested, but it just didn't work out for my DNP. But in the intensive care unit, they have the highest rate of, invasive procedure hospital-acquired infections, because most patients in the ICU have central lines, so they have the highest rate of central line infection, and sepsis. So they determined that they would use a new bath basin every day to bathe the patient if they have a central line. Or they could use those chlorhexidine, wipes. The problem with the chlorhexidine wipes, although the patient was getting a better bath than with a washcloth and soap, the patients didn't feel that way. But the worst case scenario was that someone was flushing them down the commodes, and causing major issues all over the hospital, but especially in the ICU. They still have those, but then, so you think about the garbage with all those plastic basins going out every day. So they tried, like a disposable basin, but they found out with that, the water was leaking out, and it just didn't work. So they tried several things. Where did they find that information? Through evidence-based practice. They had to look it up through research, how research studies showed what was supported best. And so I went in for her to look to see, and I found out that the chlorhexidine wipes were the best to utilize. But you know, if it's causing a major plumbing issue with thousands of dollars being utilized on plumbing, then I also found some studies that showed as long as they were using a clean bath basin every day, then that was okay too. That was supported with evidence-based practice. So we look at evidence-based practice for nursing interventions to try to make the main things for patient safety for evidence-based practice. But anytime that I want something to change here, what I love about Dean Kirkland is that if I can go and get him some research to support what I want, he actually reads it and comments on it. And I've never had a dean, they would have looked at me and laughed while they were throwing it in the garbage can, you know. But he is, of course, he's a nurse, he's a registered paramedic, and now his titles, and of course he's going back to get his doctorate, his PhD, but anyway. But again, researched interventions, and that's what you will learn also. And you know, those, the electronic health record or the WOW has the capability that if you want to look up something, say for instance, I think I told you about the former student that didn't know how to access a port. But in those days, they didn't have the WOW available. They didn't, I don't know if they had Google back then. Of course, there was, I know they had a policy and procedure book, but this girl was more for looking than for cooking, this nurse. But anyway, but now, you can, and I say that because I'm not a cook, and when we moved into our lake house, it had an ugly stove in it, and I was fine with that ugly stove. Didn't have a problem, but my husband he wanted one of these, he wanted it to match the refrigerator. Isn't that odd, that man, you know? So he wanted the stainless steel oven, and he said, I'm gonna go to Sears to get an oven, you wanna come? I thought, no, now, if you don't stop by Military or Bale, yeah, I'll go with you, but no, I'm not going to Sears looking for that. And so he went over and he was talking to the appliance salesman, and the appliance salesman was telling them about all the bells and whistles the stove had, and he said, oh no, he said, I just want it for looking, it's not for cooking. He said, in fact, if you've got a good replica of this stove, if it's just a box, I'll buy that. So, anyway, so this nurse was for looking rather than thinking maybe. So, again, rather than go look up the policy and procedure, she just thought she'd get an easy access. And again, the first thing I asked her, how busy are you? She said, I'm not that busy. And I thought, I'm not going to do this for her or show her. I mean, she was my student once, but not anymore. I had other things to do too, but I felt like if she looked it up, she would better retain it than if I showed it to her. Plus, I'm not an employee at that hospital. You know, if I was accessing that line during clinicals, that's one thing, but I was up there looking for patients for my students. So evidence-based practice. On this test coming up, there will be things that you're going to have to prioritize patients. Have y'all already had exams through Kaplan that you had to do that?
Mm-hmm.
And Kaplan and probably Hurst, but, so, if you have a patient, say a heart failure patient, and I think I brought this up before, what would you expect on them? If they were having dyspnea on exertion, would you be alarmed? Because that's common for them. Heck, that's common for me. If I walk up a flight of stairs because I'm deconditioned. If they were if they gained more than a pound overnight, would you be concerned?
Yeah.
No. It's more than 2 pounds.
2.
Or more than what, 5 pounds in a week? So you've got to know what, but if they're complaining of shortness of rest, would that be more of a priority? Because the first thing we have to worry about with a heart failure patient is pulmonary edema. Because when that fluid is pushed into different spaces, the space that we worry about the most are those lungs with pulmonary edema in those alveoli. So you've got to think about that also. What is stable for that patient and what is not stable, or what's typical for that patient. Because the next generation NCLEX, that's what they're going to. But they're going to be utilizing that with priority. They is also on testing that you can critical think what would be unstable for that, what would be typical for that patient, and what would be unstable for that patient. Okay. Any questions? You know, I very seldom have ever in my 17 years here lecturing received any questions before the exam. But after that exam, well now why wasn't question number so-and-so? Why wasn't that option correct? I get all kinds of questions then.
Go ahead, Spence.
Yeah, especially on 98 Spencer. Spencer 98. You need to change your, and I don't know what your email is, but it definitely needs to be Spencer 98. It may be you born in 98.
No, 99.
Do you know how many questions are gonna be on the Catalan quiz?
Oh, let's see. I have it written down, but I don't have that information with me. I thought I put it in the syllabus somewhere, or maybe on the calendar, but I'll look it up.
think on the syllabus it said 75.
75 hours left.
We've got one.
69.75.
One, two, until
Yeah, I was gonna say, 'cause some of mine I've stayed till like 7:40 one night.
I just
I've stayed-
round mine
one
up
day
to
it was
7:30.
7:10, one day it was 7:15.
I round mine up to 7:30.
I'm putting exactly what I like.
I'm doing
I just wanna make
7:30
sure
because some days I leave.
My lady used to make sure too. So I just wanna make sure that I'm doing things the way that everybody else is. Her name's Margie Jordan. I love her. I really love her. But I just wanna.
I just round mine up to
I just wanna
7:30
make
because
sure.
sometimes she's charged, sometimes she's RRT. One day it was RRT and I had to go to the floor and I was up there till 8.
I did. I sat in jail. The suicidal patient. That was our job that day. It was sitting. It was the worst day of my life. It was like the longest day. That I do not want a slow job. I learned that day.
Oh no, because that after there for 12 hours and everything's going
I had psych with it fine. They drove me insane.
Oh,
They're
it says
very-
50. Oh, wait a minute, no, that's the PM. Mine is the PM.
What's this for the
farm captain.
farm?
She was like a farm